Welcome to the Neurology Wing. Today we are discussing one of the most dramatic and distressing emergencies you will face in veterinary practice: seizures. A seizure is, by definition, a sudden, uncontrolled, synchronous discharge of neurons in the brain. Think of it as an electrical storm. Normally, neurons fire in an organized, rhythmic fashion. During a seizure, that rhythm descends into chaos. This results in the clinical signs we see: involuntary muscle movements, altered consciousness, and bizarre behavioral abnormalities. This is one of the most common neurologic emergencies we see in both dogs and cats. Here is the challenge. Seizures are a symptom, not a specific disease. They can arise from something inside the skull, intracranial, or something happening elsewhere in the body, extracranial. While many seizures are isolated and stop on their own, others are life-threatening emergencies requiring immediate stabilization. Our job is to figure out the why behind the storm, because in both species, a seizure is often the first red flag of a serious underlying pathology.
Not all seizures look the same. To treat them effectively, we first have to classify them. We break them down into 4 main categories. 1. Generalized seizures, also called grand mal. This is what most owners imagine when they hear the word seizure. It involves the entire brain firing at once. The look. The animal loses consciousness immediately. You see paddling, rigidity, and convulsions. The mess. There are often autonomic signs like salivation, urination, and defecation. The aftermath. Afterward, in the post-ictal phase, they are disoriented, ataxic, and sometimes temporarily blind. 2. Focal seizures, also called partial. These are trickier because they arise from just a localized area of the brain. The signs. The animal might remain conscious but show bizarre behaviors like fly biting, snapping at invisible flies, excessive lip smacking, or twitching of just one limb or side of the face. The risk. Be careful. These often spread and progress into generalized seizures. 3. Cluster seizures. This is a numbers game. We define clusters as multiple seizures occurring within a single 24-hour period. This indicates a rapidly lowering seizure threshold. 4. Status epilepticus. Finally, the true emergency: status epilepticus. This is a life-threatening state defined by one of 2 things: a single seizure lasting longer than 5 minutes, 2 or more seizures without full recovery of consciousness in between. Why it matters. After 5 minutes, the brain begins to cook. We risk permanent brain injury, hyperthermia, metabolic acidosis, and death. You must stop the electrical storm immediately.
To the owner, a seizure looks like chaos, but to us, it follows a distinct pattern. A seizure isn't just the moment of convulsions. It is a 3-part sequence: the warning, the event, and the recovery. First, the preictal phase, often called the aura. This is the electrical storm gathering strength. The pet knows something is wrong. You might see anxiety, restlessness, or compulsive pacing. Some dogs become incredibly clingy and won't leave the owner's side, while others go hide in a closet. This phase can last seconds or even hours before the actual seizure hits. Then comes the ictal phase. This is the active seizure event. This is usually tonic-clonic activity. You see rigid muscle contractions, called tonic, followed by paddling or jerking, called clonic. The animal loses consciousness, may vocalize involuntarily, and loses autonomic control. While it feels like an eternity to the owner, this phase typically lasts from seconds to a few minutes. Finally, the storm breaks, and we enter the post-ictal phase. Think of this as the brain trying to reboot after a system crash. The patient is conscious but confused. They may be temporarily blind, ataxic or wobbly, or profoundly fatigued. Interestingly, they often wake up with intense hunger or thirst. This phase is variable. It can last a few minutes, or the animal might be out of it for several hours. It is crucial to warn owners about this, or they might think the seizure caused permanent stroke-like damage.
So, what is actually happening at the cellular level when a patient seizes? It comes down to a failure of equilibrium. The brain operates on a delicate balance between excitation and inhibition, the neurotransmitters. Think of the brain like a high-performance car. Glutamate. This is the gas pedal. It is the primary excitatory neurotransmitter. GABA. This is the brake pedal. It is the primary inhibitory neurotransmitter. In a healthy animal, these two are perfectly synchronized. But in a seizure patient, the balance tips. Either the gas gets stuck, too much glutamate, or the brakes fail, too little GABA. The trigger and the damage. Anything that disrupts this chemical environment, whether it's a brain tumor, a toxin like xylitol, or hypoglycemia, can cause that tipping point. But here is why status epilepticus is so dangerous. It isn't just about the muscle spasms. The metabolic cost. During a prolonged seizure, neurons are firing so fast they deplete their energy reserves. The heat. This massive electrical output generates heat. Hyperthermia literally begins to cook the brain tissue. The end result. Combined with hypoxia, this leads to neuronal death. If we don't stop the seizure, the brain injury becomes irreversible.
Now, let's talk about the why. We divide causes into two buckets: extracranial, outside the skull, and intracranial, inside the skull. First up, extracranial causes. In these cases, the brain itself is structurally normal. It is just reacting to a broken environment. Think of the brain as the innocent bystander. Metabolic meltdowns. The most common culprits here are metabolic. Sugar and calcium. Always check hypoglycemia, especially in toy breeds or diabetics, and hypocalcemia, especially in nursing mothers with eclampsia. If the fuel or the signaling ions are off, the brain misfires. The filters. Look at the liver and kidneys. Hepatic encephalopathy, from liver shunts or failure, and uremia, kidney failure, allow toxins like ammonia to build up and poison the brain. The great pretender. Don't forget Addison's disease. The electrolyte shifts in sodium and potassium can easily trigger seizure activity. Toxic troubles. Then there are the external threats. Toxin exposure is a massive category for seizures. The pantry. Common household items like chocolate, theobromine, and xylitol, found in sugar-free gum, are potent neurotoxins. The cat killer. A special warning for pyrethrins, found in dog flea meds. Cats are extremely sensitive to these. A cat that grooms a dog recently treated with flea drops can go into severe tremors and seizures. The garage. We also see organophosphates, lead, and mycotoxins, found in moldy walnut, cheese, or garbage gut. The takeaway. If you treat the seizure but ignore the low blood sugar or the toxin, the patient will not recover. This is why blood work is non-negotiable.
Intracranial causes, the source of the storm. If the blood work is normal and there are no toxins involved, we have to look inside the skull. We call these intracranial causes. Number 1. Idiopathic epilepsy. The most common diagnosis in dogs is idiopathic epilepsy. The profile. This typically hits young to middle-aged dogs between 1 and 5 years old. It is suspected to be genetic. The cat caveat. While it exists in cats, it is much less common. If a cat starts seizing, there is usually a pathology behind it. The diagnosis. Idiopathic literally means we don't know why. It is a diagnosis of exclusion. You only diagnose this after you have ruled out toxins, metabolic issues, and structural brain disease. Number 2. Structural brain disease. If the patient is older, over 6 years, or very young, less than 1 year, we worry about structural issues. The big C. In older animals, brain tumors, meningiomas, gliomas are a primary differential. the inflammation. We also see encephalitis or meningoencephalitis, like GME in dogs. The physical. Don't forget physical insults like trauma, strokes, or congenital issues like hydrocephalus, water on the brain, in puppies and toy breeds. Number 3. Infectious invaders. Finally, we have the infections. Dogs. We screen for distemper, neospora, and toxoplasma. Cats. FIP is a major player here, along with toxoplasmosis and cryptococcus, a fungal infection often found in nasal cavities that migrates to the brain.
Clinical signs, the anatomy of an episode. Diagnosing a seizure often happens after the fact, relying entirely on the owner's description or a smartphone video. So you need to know exactly what to look for in each stage. 1. The warning, prodromal or aura phase. It begins with a behavioral shift. We call this the prodrome. The signs. The pet isn't acting right. They might become restless or irritable. You will often see extremes in social behavior. Either they are hiding under a bed, or they become intensely attention-seeking and clingy. Clinical pearl. Owners often miss this or realize it only in hindsight. But for a pet with epilepsy, this is the early warning system to get them to a safe space. 2. The main event, the ICDAL phase. Then the seizure hits. This is the ICDAL phase. The mechanics. This is usually violent. The animal falls over and loses consciousness. You will see paddling movements of the limbs like they are treading water, and often jaw-chomping or fly-biting motions. The autonomic storm. Because the brain has lost control, the autonomic system fires randomly. Expect drooling, vocalization, screaming or howling, and the release of urine or feces. Differentiation. This mess is key. If a dog collapses but doesn't urinate, defecate, or paddle, you might be looking at syncope or fainting, not a seizure. 3. The aftermath, post-ICDAL phase. Finally, the storm breaks, but the patient isn't back yet. The confusion. The hallmark of a true seizure is the post-ICDAL phase. The animal is disoriented and stumbling or ataxic. The deficits. They are often temporarily blind, bumping into walls. The drive. Paradoxically, the brain is exhausted but desperate for fuel. These patients often wake up with ravenous hunger. Safety. Be careful. Some sweet dogs can show aggression or extreme anxiety in this phase because they are confused and scared.
When a seizure patient rolls in, your diagnostic path follows a strict hierarchy. We don't jump straight to the MRI. We follow the rule of exclusion. Step 1. Stabilize. First priority 1. If the patient is actively seizing on the table, forget the paperwork. You must stop the seizure. The ABCs. Protect the airway and ensure oxygenation. The vitals. Check the body temperature immediately. Prolonged seizures cause hyperthermia that cooks the brain. The quick fix. Always check a quick blood glucose. If they are hypoglycemic, a shot of dextrose stops the seizure instantly. Step 2. The minimum database. Once stable, we hunt for extracranial causes. This requires a full minimum database, CBC and chemistry. We are looking for liver failure, kidney failure, or electrolyte derangements, calcium, sodium, potassium. Urinalysis, to rule out toxin excretion or metabolic waste issues. Liver function. Clinical pearl. In young dogs, especially Yorkies or Schnauzers, run bile acids or ammonia levels. A liver shunt, or PSS, is a classic cause of seizures after eating. Step 3. Specific diagnostics. Next, we widen the net based on history. Blood pressure. Severe hypertension can cause hypertensive encephalopathy and seizures. Infectious disease. In cats, status checks for FELV and FIV are mandatory. Toxins. If the history supports it, screen for specific toxins like ethylene glycol or lead. Step 4. Advanced imaging and CSF. If the blood work is clean, the problem is likely intracranial. This is where we reach for advanced diagnostics. When to recommend this? If the pet is less than 1 year old, suspect congenital. If the pet is greater than 5 years old, suspect tumor. If there are abnormal neurologic deficits between seizures. The gold standard. MRI is far superior to CT for looking at soft tissue brain pathology. CSF tap. After ruling out high intracranial pressure, a spinal tap helps diagnose inflammatory diseases like GME or infectious encephalitis.
Treatment starts at home. Teach clients 3 rules. Hands off. Dogs cannot swallow their tongue, but they will bite. Keep hands away from the mouth. Safety. Cushion the head and dim the lights. The timer. If a seizure lasts breath in 2 minutes or they happen in clusters, drive to the ER immediately. In the clinic, stop the storm. When they arrive, move fast. First line, benzodiazepines. Use diazepam IV rectal or midazolam. IM, intranasal, is great if you can't hit a vein. Escalation. If they keep seizing, load levetiracetam, Keppra, or phenobarbital IV. Refractory. Still seizing? Use propofol to induce anesthesia and shut the brain down. Stabilize. Once the shaking stops, check the temperature immediately for hyperthermia. Start oxygen, fluids, and always check glucose to rule out hypoglycemia.
Maintenance therapy, the long haul. We don't put every seizure patient on meds for life. It is a commitment. So, when do we pull the trigger? The rules of engagement. We start long-term therapy if seizures happen more often than once every 6 to 8 weeks. They have cluster seizures or history of status epilepticus. We find structural brain disease, such as tumor or inflammation. The post-ictal recovery is severe or dangerous. The arsenal. Choosing the right drug. Number 1. Phenobarbital, the heavy hitter. This is the first-line gold standard for both dogs and cats. It works, and it is cheap. The catch. It is hard on the liver. You must monitor serum levels and liver enzymes regularly. Number 2. Potassium bromide, or KBR, the dog exclusive. This is a salt that works wonders for idiopathic epilepsy in dogs. Warning: never give KBR to a cat. It causes fatal asthma-like pneumonitis. It is strictly for canines. Number 3. Levetiracetam, or Keppra, the safe bet, the modern favorite. It is incredibly safe, has almost no side effects, and doesn't hurt the liver. It is often used as an add-on or for patients with liver disease. Number 4. The others. Zonisamide, a great sulfa-based option for dogs with fewer side effects than phenobarbital. Gabapentin. Note this, gabapentin is not a primary seizure drug. It is too weak. Use it only as an add-on helper, never the solo hero.